I will present a triage test. A triage test is used before existing tests in a clinical pathway, with the purpose of identifying patients with a particular result, thus excluding them from requiring additional testing. Triage tests may not be as accurate as existing tests, but should have some distinct advantages, such as being less invasive or less costly. Triage tests could be beneficial with only having either a high sensitivity or high specificity to capture the highest number of cases of interest. Using a triage test may result in missing a proportion of the population of interest, such as patients with false negative results. It may result in being less effective than the existing testing pathway. It is important to evaluate whether the reduction in the effect of the triage test is adequately offset by its advantages. The current decision framework may not be appropriate for these less effective and less costly scenarios. A conventional incremental cost-effectiveness ratio, ICER, is not appropriate due to the possible negative incremental cost and negative incremental effectiveness. Although negative incremental effects and negative incremental costs yield a positive ICER, the direction of decision-making based on this ratio is different from an ICER calculated from positive incremental effectiveness and costs. My colleagues and I have proposed a non-inferiority framework for cost-effectiveness analysis. Before introducing this framework, I would like to introduce some concepts behind it. The non-inferiority products often replace the classic products in real life. I listed a few examples. MP3 has replaced CD discs, smartphones are largely replacing cameras, and fast food is replacing food cooked in the traditional way. The quality of non-inferiority products can continue improving and approaching the classic products. The same trend happens in healthcare products. For example, point-of-care testing versus diagnostic testing, which are performed at the medical laboratory, generic drug versus the brand-name drug, and minimally invasive surgery versus traditional open procedures. Our new decision framework simultaneously considers both non-inferiority and willingness to pay thresholds for these scenarios. This framework borrows concepts from non-inferiority clinical trials and assumes that if the new intervention cannot preserve a certain proportion of effectiveness by the standard clinical pathway, it should not be adopted. We consider an intervention cost-effective if two criteria are met. The new intervention is non-inferior to the active control, and the new intervention has a positive incremental net monetary benefit at a given willingness to pay. For a triage test, we can use the number of disease cases detected as the effectiveness measure. Then, we may define a threshold, such as 90%, to determine the non-inferiority. Many examples implicitly assumed the non-inferiority of the new test. This slide is the results of a published economic evaluation of using a biomarker test for pregnant women with suspected preeclampsia. The biomarker test is used as a triage test to exclude low-risk patients from hospitalization. The study results showed that compared with the no biomarker test group, the biomarker group admitted a much smaller number of pregnant women for hospitalizations. Therefore, the biomarker test group led to cost savings. However, compared with the no biomarker test group, there were a greater number of discharged patients who actually developed preeclampsia in the biomarker test group, 22 versus 11 in scenario 1. In other words, the biomarker test group missed more cases than the no test group. In scenario 2 and 3, the biomarker groups missed more cases and saved more money, too. The authors focused on the saving from the biomarker, and the implicit underlying assumption is that the biomarker strategy is non-inferior to the no test group. If we are the decision makers, we need a clinical judgment. Can we tolerate missing the additional 11 preeclampsia cases per 1,000 people?